All right, good afternoon, everybody. My name is Tara Millson. I'm a member of the Protocol and Validation team. I'm one of the subject matter experts for Ventilator-associated Events, or VAE, and I have the pleasure of talking to you today about how to use our VAE surveillance module. By the end of this session, you should be able to understand and apply the VAE surveillance module, describe how to use the VAE calculator, and then apply this knowledge to a series of example case scenarios. Okay. So we heard earlier this week from Denise, Dan, and Cindy that healthcare-associated pneumonia continues to be an important problem in healthcare. We have also learned in a multi-state prevalence study in 2011 conducted by the CDC that there are an estimated 157,000 healthcare-associated pneumonia events in U.S. hospitals each year, and that almost 40% of those are ventilator-associated. A follow-up point prevalence study conducted in 2015 found that the prevalence of these HAIs were about the same. Likewise, CMS data between 2005 and 2013 found that the prevalence of ventilator-associated pneumonia to be unchanged. And they estimated that about 10% of patients on ventilators will develop a pneumonia associated with that ventilator. So we still have some work to do to prevent pneumonia in ventilated patients. This is a really important complication, but there are other adverse events that can be just as harmful to patients. Thus, we have our ventilator-associated event module. This is intended to detect these serious adverse events which may be related to the ventilator, including possible ventilator-associated pneumonia, or VAP. The fundamental basis of VAE surveillance is the VAC, VAC, or ventilator-associated condition. This is characterized by evidence of a deterioration in oxygenation with relatively high thresholds of change in PEEP, or FiO2, after a baseline period of stability. Detection of a VAE may be related to an infectious process, or it may indicate some other adverse event is occurring, such as fluid overload, acute respiratory distress syndrome, or ARDS, or atelectasis. Many of these complications are potentially preventable. The information that you gather from this surveillance module can be used to initiate actions in your facility to improve the outcomes of critically ill patients by identifying areas for improvement in the care and management of ventilated patients. When this surveillance module was being developed, the goal was to have a protocol that was objective, reliable, and had the potential to automate data collection. VAE is currently the only module that is available for in-plan surveillance for respiratory events in adult locations. In 2013, the VAE surveillance module replaced the ventilator-associated pneumonia module because it is important to try and prevent all adverse events, not just ventilator-associated pneumonia. You may still perform pneumonia or new surveillance using the new module, but these events are available for off-plan use only. And we also have a separate VAE module that was developed for pediatric locations, which you learned about yesterday from Cindy. Cindy gave us a great overview already of in-plan and off-plan uses of the protocols, but let's quickly review what in-plan means. When you follow a module in plan, that means that you are following it in its entirety. You've selected it in your monthly reporting plan, and that when you're performing VAE surveillance, that you will be reporting any event that you identify, including a VAC, an IVAC, or a PVAP. You can't select just to follow, for instance, PVAP or IVACs. You have to follow the module for all three events. The NHSN application can help you to determine the protocols that you can follow in plan. When you're making your monthly reporting plan, the modules which are available for selection will depend on the type of location. In this example, radiology is a non-bedded location, and therefore VAE surveillance is not available. The burn ICU and the cardiac ICU are both adult inpatient locations, so notice that VAE is available, but PED VAE is not. Similarly, the pediatric locations are allow you to select PED VAE, but VAE surveillance is not available. And just as a reminder, the Definitions that are located in Chapter 2, such as POA or the repeat infection time frame, we do not use those in VAE surveillance. And before we get started, I wanted to introduce you to some new training modules that came available in the latter part of 2018. These are located on the NHSN website, and there are 2 computer-based training modules which cover this topic. All right, so let's talk about VAE surveillance. As mentioned earlier, this approach for VAE surveillance was launched in 2013. We anticipated that there would be adjustments made to the protocol, and there were. In part, these changes were based on feedback that we received from users like yourselves. I won't go into all of the specifics, but I wanted to point out that this is a living document and that we constantly seek to improve and enhance the module to make the data that we collect meaningful and useful. As you can see, the more we learn from your surveillance efforts and the feedback that we receive from you, the better and more comprehensive we can make this protocol. Many of the changes in the most recent years reflect new technology that's been developed to detect and to treat infection. We have also made several clarifications to our definitions to enhance the ability of the end user to apply the definitions and to ensure consistency of the data that is collected. The antimicrobial list is frequently updated as new agents are added by the FDA. In 2018, we changed the PEEP and FiO2 criteria to include values which are maintained for greater than 1 hour. We added cytology findings to PVAP criterion 3, and aprv was no longer a required field for event reporting. We also removed IVAC plus from the rates and the SIRS because VAE may be a better measure for use in public reporting and interfacility comparisons. In 2019, the protocol that you're working with now, we updated ventilation support modalities which are excluded from VAE surveillance to include paracorporeal life support when it's in place for the entire calendar day. Please note that this exclusion applies only when there is an oxygenator that is part of the life support circuit. The addition of oxygen to the blood via the oxygenator would not make it possible to apply the VAE criteria, which are based on changes in the FiO2 from the ventilator. We also updated the IVAC criteria in the algorithm to clarify that a new antimicrobial agent must be continued for at least 4 qualifying antimicrobial days instead of 4 calendar days. And we added an update to the antimicrobial list in the appendix of the protocol. Okay, so who are the patients that are eligible for inclusion in VAE surveillance? We are talking about inpatients of acute care hospitals, LTAC facilities, and inpatient rehab facilities who are housed in adult locations. Pediatric patients in adult locations are included in VAE surveillance. However, if this includes young children that are not thought to be physiologically similar to the rest of the patient population, you might want to consider using a virtual location to report their events. Patients who are not eligible for VAE surveillance include those that have not been ventilated for at least 3 days, patients who are on high-frequency ventilation or paracorporeal or extracorporeal life support with an oxygenator, and patients who are being housed in a non-acute care location in an acute care setting. Notice that we did not mention any exclusion in the previous slide about pneumonia that is present on admission or pneumonia that is present before intubation. Remember that POA is not used anywhere in the VAE protocol. And please note that VAE and NU are separate and distinct events, and it is possible to meet the definitions in one, both, or neither protocol. We get a fair amount of questions about this, and it's important to remember that VAE and pneumonia are not synonymous. VAE can detect a wide range of events that the pneumonia protocol cannot. I do want to point out that patients who are receiving conventional mechanical ventilation and also receiving therapies such as prone positioning or nitric oxide are eligible to be included in surveillance. Additionally, the use of a mode of mechanical ventilation called airway pressure release ventilation, or aprv, can be common in some ICUs, and patients on this mode are also eligible for inclusion in VAE surveillance. Let's look a little more closely at what aprv is. This is a mode of mechanical ventilation characterized by continuous application of positive airway pressure with an intermittent pressure release phase. This is used in patients with acute lung injury and acute respiratory distress syndrome, and it may also be used after major surgery to prevent atelectasis. I would encourage you to talk to your respiratory therapist for more information about this, also to find out how often it's used in your facility and how you would be able to identify that a patient was on this by looking at the medical record. While patients are on aprv or similar modes, they are included in VAE Surveillance, and it's important to note that evaluation for the VAC event will be limited to the FiO2 parameter only when this patient is on for the entire calendar day. When this happens, you'll record just the FiO2 and you will mark the PEEP as NA. Don't mark it as 0, mark it as NA, and that's important, and we'll talk about that later. If the patient is on this modality for a portion of a calendar day, do not record PEEP during the time period that they were on aprv, but you will record PEEP during the time period of that calendar day that they're on a conventional mode of ventilation. To start, let's review a few key definitions. A ventilator is defined as a device that is used to support respiration through the application of positive pressure when delivered through an artificial airway, specifically an oral or nasal endotracheal tube or a tracheostomy tube. Some things that are not considered a ventilator are devices which apply positive pressure to the airway from some external device, for instance, through nasal prongs or a face mask. We commonly see this with CPAP or BiPAP. Or rarely used devices such as the iron lung, which applies negative pressure, and I have a picture of here. Another key term is episode of mechanical ventilation, which is defined as a period of days during which a patient was mechanically ventilated for some portion of each consecutive day. A break in mechanical ventilation of one full calendar day, at least one full calendar day, would be necessary to start a new episode of mechanical ventilation. So if a patient is on and off a vent during a calendar day, that is still considered one continuous episode of mechanical ventilation. Or, for example, if the patient is extubated today but reintubated tomorrow, that would still be considered one continuous episode of mechanical ventilation. If they were extubated today and they spent all day tomorrow off of the vent and then were reintubated on Friday, Friday would start a new episode of mechanical ventilation. All right, so let's talk about the VAE algorithm. I do want to emphasize that this is a surveillance algorithm. It is not a clinical definition, and it's not intended to be used in the management, the clinical care of patients. Okay, so this slide shows you an overview of the VAE algorithm. You can see there are 3 tiers. There is a respiratory status component, an infection or inflammation component, and finally, additional evidence which indicates a possible VAP. The algorithm is progressive, such that to have an IVAC, one must have already met the VAC criteria, and to have a PVAP, one must have already met the VAC and IVAC criteria. It may be helpful to consider that having an IVAC is not necessarily worse than having a VAC. The algorithm is progressive in terms of the criteria to be met from VAC to IVAC to PVAP, but this is not to imply that each subsequent tier is more clinically significant than the one before. The fundamental definition within the algorithm is the VAC, which is defined on the basis of respiratory deterioration. It doesn't consider any antimicrobial therapy or any laboratory findings. So even in those situations where an IVAC is detected, that event still met the VAC definition. It's just that there is some kind of additional evidence that it may be infectious in nature and may possibly be related to the lower respiratory tract. Okay, so because the VAE algorithm is progressive, let's start with the first tier and learn how to determine if there is evidence of respiratory deterioration. Here we have a screenshot of the algorithm that exists within the protocol. Using the daily minimum FiO2 and daily minimum PEEP, we observe for a baseline period of stability or improvement on the ventilator, followed by evidence of worsening of oxygenation. A point to remember is, if the baseline is established in FiO2, the evidence of worsening oxygenation must also occur in that same parameter. In other words, you can't meet a VAC definition if there is stability in in FiO2, but evidence of worsening oxygenation in PEEP. Let's briefly discuss what FiO2 and PEEP are, because these are the foundation of the VAE detection. PEEP is used to keep a patient's airway open at the end of exhalation. To meet the VAC criteria, the daily minimum PEEP must have a sustained increase of at least 3 centimeters of water. We also refer to that as 3 points or simply 3 over the baseline period to indicate a worsening of oxygenation. FiO2 is the fraction of of oxygen, which is in inspired air. For example, the air in this room contains 21% oxygen. This is often expressed as 0.21 or 21%, or simply 21. To meet VAC criteria, there must be a sustained increase of at least 20% over the baseline period to meet the VAC criteria. Okay, we've defined PEEP and FiO2, but what are we talking about when we say daily minimum PEEP and FiO2? It's really important that you have a good understanding of what these values are and how to make the daily minimum value selection, because remember that this is the foundation that must be met before any other criteria can be considered. So when a patient is ventilated, the FiO2 and PEEP ventilator settings that are documented across the calendar day are what we use to identify the daily minimum PEEP and FiO2. And by documented, we mean that it is recorded in the medical record somewhere or on a respiratory or nursing flow sheet relative to that ventilator. And remember to use calendar day and not some other capture period, not some other random 24-hour period. This really helps with standardization of data collection because we can be sure that everybody is collecting data for each calendar day. Keep in mind when choosing the daily minimum PEEP and FiO2 to include all settings while the patient is on an eligible mode of mechanical ventilation. You want to include all settings when the patient is on a weaning or a liberation trial as long as the patient is ventilated. Do not include trached patients who are on simply on supplemental oxygen like a trach collar. And if patients are receiving support using an excluded mode of ventilation intermittently throughout a calendar day, you can still use the settings that were documented while the patient was receiving a conventional mode of therapy. You want to exclude settings that are documented during times when a patient is on an excluded form, such as high-frequency ventilation or ECMO, or during times when a patient is not receiving mechanical ventilator support but may have an artificial airway, such as during a T-piece trial. Also, during periods of time, as a reminder, when patients are on aprv for a portion of the day, you would only review FiO2 data during the period of time that they're on that aprv. From the eligible documented settings, you will choose the lowest FiO2 and PEEP setting during the calendar day that was maintained for greater than 1 hour. If there is no value that has been maintained for at least 1 hour, then you'll select the lowest value available regardless of the period of time in which the setting was maintained. This may occur if a patient is ventilated late in a calendar day, or if it's discontinued early in a calendar day, or if somebody has really unstable vent settings and they're going up and down all day. Okay, so let's get a visual. Documentation in the medical record may look something like this. The mode of ventilation is an eligible mode, and the FiO2 and PEEP have been documented 8 times over the course of the calendar day. When documentation of the settings takes place in intervals greater than 1 hour, as in this case, it's easy to determine which values have been maintained for at least 1 hour. So in this example, the daily minimum values for this calendar day are 70 for FiO2 and 5 for PEEP. These are the values that are of interest for this calendar day. When settings are documented at a frequency that is less than 1 hour, it can be a little tricky, but there is specific guidance in the protocol for these instances. For example, if you're tracking every 15 minutes, you would need at least 5 consecutive recordings at the same level in order to meet the greater than 1 hour threshold. If you're tracking every 30 minutes, you would need 3 consecutive values to be recorded. And if you're tracking every hour, you would need at least 2 consecutive values to be recorded in order to count that. In this example, there are periods of time where the values are documented on an hourly basis, so it is important to choose the value that was maintained for greater than 1 hour. Following the protocol guidance, in this example, the daily minimum FiO2 is 75, and the daily minimum PEEP is 8. $70 is the lowest FiO2 that's recorded for the calendar day, but it was not maintained for 1 hour. At 3 a.m., it was 70, and at 4 a.m., the setting was recorded at 90. Okay, let's look at an example where there may not be a time frame in which any value has been maintained for at least an hour. Let's look at Monday on this table. It's the blue on the left. So this is an example of a patient that was intubated late in a calendar day. The daily minimum FiO2 would be 70, and the daily minimum PEEP would be 5. Okay, so let's start with our knowledge check. Mrs. Apnea was intubated at 10 a.m. Below are the PEEP and FiO2 settings, which were documented for the remainder of the calendar day. What are the daily minimum PEEP and FiO2 values for this day? And we have a poll everywhere. If you need to refer to the table, it's in your handout. Okay, and the correct answer was B, and most of you did select that. A PEEP of 5 and an FiO2 of 40. In this instance, the settings are documented every 2 hours, so each value is maintained for greater than 1 hour. Okay, knowledge check 2. Mr. Blue Lips was intubated at 6 p.m. The PEEP and FiO2 values for the remainder of the calendar day are displayed on the table below. What are the daily minimum values for PEEP and FiO2 for this calendar day? And we have another poll everywhere. If you need to refer to the table, again, it's in your handout. All right, good. It looks like about 3/4 of you selected C, which is 8 and 75, and that is correct. The correct answer is PEEP of 8 and an FiO2 of 75. The settings are documented every hour, and we know that an eligible setting must be maintained for greater than 1 hour. At 9 p.m., we do have an FiO2 value of 50, and we also have a PEEP of 5. But at 10 p.m., both of those values changed. So they were, although they were the lowest, they were not the daily minimum value because they were not maintained for greater than 1 hour. Okay, and we have our next knowledge check. In most circumstances, when selecting the daily minimum PEEP and FiO2 for each calendar day, what would you do? All right, great. It looks like most of you selected B, which is correct. You would look for the lowest value that has been maintained for greater than 1 hour. These values are collected, recorded, and evaluated to determine if the VAC definition is met. They are used to assess for both the period of stability or improvement and the period that indicates a worsening of oxygenation. Remember, you will not be comparing values that occur within a calendar day to determine stability or worsening of oxygenation within that day. Another important note is that for the purposes of VAE surveillance, PEEP values between 0 and 5 are considered equivalent. Okay, so we have reviewed the daily minimum value concept, and now let's make sure we understand the baseline and the worsening concepts of the VAC definition. So let's review the elements of VAC. First, a period of stability or improvement must be observed, which is defined as at least 2 calendar days of stable or decreasing daily minimum PEEP or FiO2 values. Next is the baseline period, which are the 2 days immediately preceding the first day of worsening oxygenation. As discussed on the last slide, to meet the VAC definition, you must have a baseline period that is immediately followed by evidence of worsening oxygenation. This is indicated by either an increase in the daily minimum FiO2 of at least 20% over the daily minimum value of the first day of the baseline period, which is sustained for at least 2 calendar days, or an increase in the daily minimum PEEP of at least 3 over the daily minimum value of the first day in the baseline period, which also must be sustained for at least 2 calendar days. Clear as mud, right? For some reason, this was the most difficult concept for me to grasp. But don't worry if you're feeling a little bit confused too. I have some visuals that I think will help you to grasp this more fully. So let's get a visual. All right, so here we have values that are the same. This would meet the baseline period of stability. We have 3 consecutive days of 30 stable values. Here we have values that are decreasing, go from 35 to 35 to 30. This would be a baseline period of improvement. This is an example of what a VAE worksheet might look like in your facility. In this example, stability can be observed in PEEP and FiO2. However, it's important to know that they don't have to be stable in both or improving in both. You can just have it in one parameter. Note that the establishment of stability can occur within the first 2 days of mechanical ventilation, but the event itself cannot occur until at least mechanical ventilation day 3. Since if you recall from our earlier discussion, the patient must be on the vent for greater than 2 calendar days to be eligible for VAE surveillance. Also note the baseline period can be demonstrated by stable or improving vent settings, and in this case, it's stable settings. Okay, so we have established a baseline period of stability on vent days 2 and 3. In this example, there is an increase over the baseline period in the PEEP parameter of at least 3, which satisfies the requirement for meeting the VAC definition. The increase must be relative to the first day in the baseline period and must be sustained for at least 2 calendar days. What I mean by this is if day 5, the PEEP had dropped back down to 7, the definition would not be met because the increase was not sustained for at least 2 days, and it wouldn't be at least 3 greater than the first day of the baseline period. In this example, the VAC definition is met in the PEEP parameter because we have greater than or equal to 2 days of stability immediately followed by greater than or equal to 2 days of worsening oxygenation. But before we move on, let's review why the VAC definition was not met in the FiO2 parameter. Worsening is determined relative to the first day of the baseline period. Looking at the FiO2 parameter, there was a baseline of 40 for 2 days and an increase to 60 immediately followed that baseline, but the next day was 50, which does not meet the threshold of an increase of 20 over the first day in the baseline period. The worsening is not sustained in the FiO2 parameter, therefore a VAC would not be met in this parameter. Okay, now let's check 4. What if an increase over the baseline period meets the requirement relative to only 1 baseline day? Would you have a VAC or no VAC? All right, great. Looks like the vast majority of you said there would be no VAC, which is the correct answer. The increase must be at least 3 over the daily minimum value in the first day of the baseline period. And as you can see here, the increase to 8 meets the threshold of at least 3 points over the baseline only of the value of 5. It does not meet the baseline value of 7. Therefore, the VAC definition is not met. Okay, our next knowledge check. What if there is an increase for 1 day and then a decrease? With these values, would we have a VAC or no VAC? All right, 100% said no VAC. And you're absolutely correct. This would not be a VAC because the increase is not sustained. At the required threshold for at least 2 days, the value of 7 is not at least 3 above the baseline. Very good. All right, knowledge check 6. In this circumstance, would you consider this a VAC or not a VAC? I think VAC is pulling ahead. All right, let's see. This would be a VAC. Both days of the baseline period have a PEEP value of 5. The 2 days of worsening oxygenation, in this case the 10 and the 8, meet the criteria of at least 3 points above the baseline, and the increase was sustained for 2 calendar days. So even though the values change from 10 to 8, they still meet that threshold of 3 over the baseline period. Therefore, VAC definition is met. Okay, on this slide, we have PEEP going up, but FiO2 goes down. Would we have a VAC or not a VAC? All right, we have just about most of you that said we would have a VAC. So remember that each parameter is independent of the other. It is possible to have an increase in one and a decrease in another, which meets the VAC criteria. In this scenario, VAC definition is met. Very good. Okay, so hopefully by now you have a pretty good understanding of the baseline period of stability or improvement and finding evidence of worsening oxygenation to help you determine if a VAC has been established. Next, you'll want to know the date of event. This is defined as the date of worsening of oxygenation. The earliest possible date for this is mechanical ventilation day 3, because remember you need 2 days of stability before you can have evidence of worsening oxygenation. So here in this PEEP parameter, we have the 2-day baseline period of stability, followed by a 2-day period of worsening oxygenation. Recall from the previous slide that the date of event is the date of onset of worsening oxygenation. So in this example, it is mechanical ventilation day 4. So why is the date of event important? This date is important because it will determine the VAE window period during which all criteria for other events, such as IVAC or PVAP, must be met. It also sets the 14-day VAE event period during which another VAE may not be reported. The full 14 days must elapse before another VAE can be identified and reported. Any data collected during this 14 days also cannot be used to upgrade the VAE unless it occurred during the window. Any blood cultures which are deemed secondary to a VAE must be collected during this 14-day event or this 14-day time period. Okay, so the event date is important because it defines the VAE window. So what exactly is the VAE window? Recall that it is the period of time during which all the event criteria must be met. It's typically 5 days, including the date of event, the 2 days before, and the 2 days after. So if the event date or the date of worsening oxygenation is mechanical ventilation day 13 in this example, the VAE window includes the event date, the 2 days before, mechanical ventilation days 11 and 12, and the 2 days after, or event days 14 and 15. All other criteria used to meet IVAC or PVAP must occur during this window period. However, with every rule, there's always an exception. When events occur early in the mechanical ventilation episode, such as on mechanical ventilation day 3 or day 4, the VAE window period may only be 3 or 4 days in length because it cannot include any days before the 3rd day of mechanical ventilation. For example, if the VAE event date is on mechanical ventilation day 3, then the window period includes only the date of event and the 2 days after VAE onset. Okay, so let's get a visual of this. Remember, eligibility for VAE requires that a patient must be on mechanical ventilation for greater than 2 days. So data other than the establishment of the baseline period cannot be used from those first 2 days of mechanical ventilation. In this case, the date of event is mechanical ventilation day 3, and the VAE window period is shortened to 3 days, the date of event and the 2 days after the event. All of the criteria would have to fall within that 3-day period. In this case, the date of event is mechanical ventilation day 4, and the VAE window period is shortened to 4 days, the date of event, 1 day before, and 2 days after the event. In this case, there is only 1 day before the event date because we can't use the first 2 days of mechanical ventilation. Okay, so we have a good foundation and understanding of the respiratory status component of the VAE algorithm. Let's move on to the next tier and determine if there's any evidence of inflammatory response or infection. So for IVAC, the patient meets VAC on or after day 3 of mechanical ventilation, and then within 2 calendar days before or after the onset of worsening of oxygenation, a patient must meet both of the following criteria: either a temperature of greater than 38 degrees Celsius or less than 36 degrees Celsius, or a white blood cell count greater than or equal to 12 or less than or equal to 4, and a new antimicrobial agent is started and continued for at least 4 qualifying antimicrobial days. This is right from our VAE algorithm in our protocol. A note about temperature and white blood cell count: if there are values that are documented during the VAE window period that fall outside of those minimum and maximum values for either of these measures, they should be used to determine if the patient meets the IVAC criteria. It doesn't matter if those were also present prior to the event or if they were present on admission. They still have to be counted if they fall within this window period. So back to our worksheet, we have the appropriate VAE window period shown in pink. We have multiple times when the temp and the white blood cell criterion is met. Remember that these should only be collected once the VAC criteria have been met, because that will set the VAE window period where you will look for temperature and white blood cell count. You don't have to look for this until the VAC has been met. Okay, so our next knowledge check: if you're performing Inplan VAE surveillance in an ICU, the IP will need to gather minimum and maximum temperatures and white blood cell counts for all ventilated patients. Is that true or false? Yeah, it's false, and most of you selected that. Remember that the VAE algorithm is progressive. If I'm conducting VAE surveillance, there is no need to routinely gather additional information on ventilated patients. You only select temp, or you only look for temp and white blood cell count once the VAC has been met. and you only look for administered antimicrobial agents once the temperature and white blood cell criteria have been met. Okay, so the next criteria that must be met for IVAC determination is for a new antimicrobial agent to be started during the VAE window period and continued for at least 4 qualifying antimicrobial days. A new antimicrobial agent is one that is listed in the appendix section of the protocol and which is initiated on or after day 3 of mechanical ventilation and within the VAE window period. An important note is that it doesn't have to be the same antimicrobial agent which is administered for the 4 QADs. They just have to meet the definition of new. Now, once you fully understand daily minimum values and you have the baseline and worsening concepts figured out, the antimicrobial criterion is probably the most complicated portion of VAE surveillance. This is not a perfect definition, but we need a standardized way for facilities to collect this data without having to spend a lot of time scouring charts looking for evidence of renal dosing or indications for therapy, things like that. The antimicrobial agents which are eligible for use to meet the IVAC criterion are located as an appendix in our protocol. There are mostly antibiotic agents and antifungals, but we do have a few antivirals that are also included. But drugs that we exclude are those that are used to treat HIV, tuberculosis, hepatitis, antiparasitics, and herpes virus infections. The IVAC definition was not originally developed to identify respiratory infections alone, and therefore the list of antimicrobial agents eligible for meeting the IVAC antimicrobial criterion was broad, and it included drugs that are not used to treat respiratory infections commonly. This caused concern and confusion among users, particularly in situations where the new antimicrobial agent that resulted in an IVAC determination and then subsequently a PVAP was not an agent that was used to treat a respiratory infection. So we discussed some possible solutions to this, and we felt that it was important to come up with a solution that would avoid increasing the complexity of this already complex criteria. Therefore, the decision was made to refine the existing IVAC antimicrobial list by removing selected antimicrobial agents such as oral cephalosporins or penicillins or Bactrim or oral vancomycin. And the list that we're left with are ones that are commonly used in ICUs to treat critically ill patients or for respiratory infections. So how do we figure out if there were at least 4 days of therapy? We term the days qualifying antimicrobial days. And a qualifying antimicrobial day is a day on which a patient received a new antimicrobial agent within the VAE window period. 4 consecutive QADs are required to meet this criterion, which means that if a patient expires or for some other reason does not complete at least 4 qualifying antimicrobial days, they cannot meet this criterion. QADs, or qualifying antimicrobial days, may be met with different agents as long as each meets the definition of new. Days between administration of the same agent may also count as QADs. And we see this at times, for example, patients that are on renal dosing for antibiotics, they might get them every 48 hours. So the day in between would still count as a QAD. Okay, so let's get a visual. This is a screenshot from the VAE Calculator, which if you aren't already familiar with it, you will be by the end of this presentation. On here, you can see that the QADs are indicated. Please note that the QADs can extend beyond the VAE window as long as the antimicrobial agent is initiated on or after mechanical ventilation day 3 and within the VAE window period. Let's look at QADs in terms of the same agent being administered. Days between administration of the same antimicrobial agent count as a QAD as long as there is a gap of no more than 1 calendar day. So in this example, ceftazidime was administered on mechanical ventilation days 5, 7, and 9, but the days in between the administrations count so that we have QADs on mechanical ventilations day 5 through 9. Also shown here, as long as the antimicrobial agent was new, started within the VAE window period, that the accrual of QADs in this example as well can extend beyond the window period. By contrast, when looking at different agents being administered, days between administrations do not count as QADs. The date of initiation of the antimicrobial agent is really important. You can see here the instruction from the calculator to include all days of antimicrobial administration, which are shown on the screen. And you see that we have checkboxes that extend above and below the VAE window. The calculator needs this information to be accurate in order to give you the correct determination. So when you're filling the information out, make sure you select all days that the antimicrobial was administered that are available on the screen. Having the correct administration days is important because an antimicrobial will not meet the definition of new if it is not administered for the first time on or after the third day of mechanical ventilation and in the VAE window. So you can see here this example, this is not a new antimicrobial because it was started prior to the window. Right, this is not a poll everywhere. This is just kind of a think to yourself kind of question. But do you count an antimicrobial agent as new if it is new as a result of de-escalation or simply a switch from one agent to another within the same antimicrobial drug class? And this is a question that we see pretty frequently from our users. The answer is yes. Although we applaud and support antimicrobial stewardship activities to avoid additional substantial complexity, there are not rules or exceptions for changes that represent a narrowing of spectrum or a de-escalation of therapy. These kinds of situations are very difficult to operationalize in a way that is easy to implement and to standardize across facilities. So to summarize, meeting IVAC does not necessarily mean that the infection-related event is necessarily respiratory in origin. The IVAC antimicrobial list was refined by removing antimicrobial agents that would not be used or would be unlikely to be used in a critically ill patient with a lower respiratory tract infection. It is still possible that an agent that the patient is on may have a dual purpose or may not necessarily be treating a respiratory infection, and there is no need to discern the reason that the patient is on the antimicrobial. For instance, if they're on prophylaxis or de-escalation, if it meets the criteria, it still needs to be used for IVAC. Okay, so let's move on. We have determined the criteria for respiratory deterioration and how to evaluate for the presence of an infection or an inflammation. Now let's move on to determining if there is additional evidence that the deterioration and infection may be due to a possible pneumonia. It is important to remember that this is a surveillance definition, not a clinical one, and this is not meant to be diagnostic or to guide clinical care in any way. Okay, so we have Tier 3, PVAP. Criteria for VAC and IVAC must have already been met before you can proceed to these criteria. Lab tests which are used to meet these criteria must occur on or after day 3 of mechanical ventilation and within the VAE window period. Certain organisms are excluded, including normal respiratory flora, community-associated respiratory pathogens, and Candida or yeast, coag-negative staph, and Enterococcus species, unless collected from lung tissue or pleural fluid. In addition, one of the following criteria must be met. This is another screenshot from our algorithm contained in our VAE protocol. I will try and save your eyesight. I'm not going to make you read all this tiny print, and we'll look at each of the criteria in detail in the next few slides. So for PVAP criterion 1, you must have a positive culture from one of the following sources which meets the quantitative or semi-quantitative thresholds outlined in the protocol. You need an endotracheal aspirate, a bronchoalveolar lavage, lung tissue, or protected specimen brushing. And note that sputum is not an acceptable specimen for meeting this criteria, and there's no requirement for criteria 1 for there to be purulent respiratory secretions. Okay, so how can you meet the quantitative thresholds of PVAP criteria 1 if your lab does not send you quantitative results, or if they send you semi-quantitative results? We get this question frequently. First, you want to talk to your lab and find out what the corresponding semi-quantitative result would look like. If they don't know, then for purposes of VAE surveillance, we allow the semi-quantitative result of moderate or heavy growth, or 2+, 3+, 4+ growth to meet this criterion. For PVAP criterion 2, purulent respiratory secretions are an element of this criterion. And we define this as a specimen that has at least 25 neutrophils and 10 or less epithelial cells per low power field, and a positive culture of sputum or endotracheal aspirate, bronchoalveolar lavage, lung tissue, or protected brush specimen that does not meet the quantitative thresholds from criteria 1. And again, what if your laboratory reports gram stain or direct exam results in a manner that does not quantitate neutrophils or epithelial cells? Again, check with your lab and find out what the corresponding value might be. And if they can't give you guidance, we have an FAQ, number 19, that you can refer to. And we also have a table that's in our protocol, table 2. And this is what it looks like. We won't go through all of this in detail, but I wanted to show you what it looks like so that you can refer to it when this question comes up in your facility. For PVAP criterion 3, this can be met by one of the following positive results: a pleural fluid culture when obtained during chest tube insertion or thoracentesis, a non-culture-based testing method or histopathology result, which indicates an abscess formation, evidence of fungal invasion of lung tissue, or infection with a viral pathogen. Or, there's more criteria on the next slide, a diagnostic test for Legionella, or a diagnostic test on respiratory secretions, which is positive for influenza, RSV, parainfluenza, rhinovirus, human metapneumovirus, or coronavirus. A note on pathogens identified utilizing a non-culture-based testing. This may be identified through antigens or serology or a PCR test. So an important note about pathogens is they are only reported for PVAP, not for IVAC or VAC. Identified pathogens are reported to NHSN using the same methodology as for other reported events, with the exception of excluded pathogens for this event type. Let's review those excluded pathogens one more time. Includes Candida species or yeast not otherwise specified, coag-negative staph, and Enterococcus species when identified from sputum, endotracheal aspirates, bronchoalveolar lavage, or protected specimen brushing. When Candida species or yeast, coag-negative staph or Enterococcus are identified from lung tissue or pleural fluid, these organisms may be reported as PVAP in certain circumstances. Additionally, as mentioned earlier, community-associated fungal pathogens are excluded. Okay, so what if I have a bronchoalveolar lavage culture report similar to this? So you have normal flora with many Pseudomonas aeruginosa and moderate Candida species. Can you use this to meet criterion 1 of the PVAP definition? It's not a knowledge check, it's just kind of a think to yourself. I'll give you the answer. And the answer is yes, because an eligible pathogen, in this case the Pseudomonas, accompanied by an excluded organism, in this case Candida, may be used to identify the PVAP criterion. You'll notice that this result was reported with the semi-quantitative result of many, which is acceptable for PVAP criterion 1. Okay, so what if a pathogen is identified outside the VAE window period, and then during the VAE window period, the same pathogen is identified again? Can I use that pathogen identification to meet a PVAP criterion? And the answer is yes. Recall that it doesn't matter if a patient has had previous prior cultures. If an eligible pathogen is recovered from an eligible specimen, which was collected during the VAE window period, it should be used for determining if a PVAP is met. Okay, let's get a visual. So here we have VAC is met, IVAC is met, and we have a quantitative report of 10 to the 5th CFUs of an eligible pathogen from an endotracheal aspirate which satisfies PVAP criterion 1. If there was not a quantitative report, but there was a report of moderate or heavy growth, the PVAP definition would have also been met. Here we have an example of how PVAP definition criterion 2 could be met. Again, VAC has already been met, IVAC has been met, and we have satisfied the purulent respiratory secretions definition because we have a specimen with greater than 25 neutrophils and less than 10 epithelial cells, and a qualitative report of an eligible pathogen from an endotracheal aspirate, which did not meet the threshold for criterion 1. And this slide demonstrates meeting PVAP criterion 3. This is a less common means for meeting the PVAP definition. A pleural fluid culture result is growing Candida albicans. Note any report of a pathogen from pleural fluid, regardless of quantity, including excluded pathogens, will satisfy this PVAP criterion. Okay, so let's talk about blood cultures. What happens when we have blood cultures that occur around the same time as a VAE? A secondary BSI may only be reported for PVAP and only when the following requirements are met. You have to have one organism from the blood culture specimen that matches an organism from an appropriate respiratory tract specimen collected during the VAE window period. Also, the blood culture was collected within the 14-day event period. Secondary BSIs are not reported for VAC or IVAC because organisms are not an element of either of those two definitions. And keep in mind that a secondary BSI cannot be reported for a PVAP when a respiratory culture was not performed. For example, if you met the criterion 2 with purulent respiratory secretions or with a histopathology criterion. So what happens if there's no VAE definition's been met, or you've only met VAC or IVAC, but you also have this blood culture that you're looking at? Or what if you have a PVAP and a positive blood culture, but the blood culture is determined not to be secondary to VAE? You can determine if the BSI is related to another site-specific infection, such as pneumonia or an SSI, or if you are unable to meet one of the site-specific definitions, you will have to evaluate whether you have a primary BSI or a CLABSI. Okay, for knowledge check 9, a patient in your ICU has met the IVAC definition. On the VAE date of event, there was a positive blood culture which grew Acinetobacter baumannii, and on the same day, the physician documented in the medical record that the patient had pneumonia. The patient also has a tunneled central dialysis catheter which has been accessed for dialysis. How should this event be reported? All right, you guys are right on the ball today. You're absolutely right. You would report an IVAC. Remember that the physician documentation of pneumonia is not an element to meet PVAP, so you have not met criterion for PVAP. You have an IVAC, but you also have this blood culture. You don't want to ignore it. You want to look at it, see if it's HAI, possibly a CLABSI related to the dialysis catheter. Very good. Okay, so we have two final terms to review, location of attribution and the transfer rule. The location of attribution is the inpatient location where the patient was assigned on the day of the VAE, which remember is the day of worsening oxygenation. And the location of attribution is subject to the transfer rule, which is if the VAE date of event is on the day of transfer or the day following transfer from one inpatient location to another in the same facility or between facilities, the event is attributed to the transferring location. So let's get a visual of that. In this example, the patient has a VAE date of event in SICU on mechanical ventilation day 4. The patient was transferred from MICU to SICU 2 days prior to the VAE date of event. and not on the date of event or the day before. Therefore, the VAE is attributed to the SICU. In this example, the patient also has a VAE date of event on mechanical ventilation day 4, and the patient is transferred from MICU to SICU on mechanical ventilation day 3. Because the VAE date of event it occurs on the day following the transfer, it is attributed to the transferring location, in this case MICU. Okay, so let's move on to conducting VAE surveillance and reporting events into NHSN. So people typically learn new information through hearing, seeing, and doing. You've been listening to me for about an hour, and I've tried to incorporate visuals to help to see this information in your brain. But to help those little information seeds to blossom, when you get back to your facility, review the protocols, read our FAQs, become familiar with our website, and check out all the tools that we have available to help you with VAE surveillance. This is what our VAE webpage looks like. Note that we have collapsible tabs which contain the protocols, FAQs, and other items which are designed to facilitate VAE surveillance. For example, the training tab has the 2 CBTs that I mentioned earlier, but there are also videos of live training events, and presumably in a couple months, this video will be up there as well. The protocol tab houses the VAE protocol, of course, but it also contains general NHSN protocols which can help you in your surveillance efforts. And then the calculators and worksheets. This is where you can find specific tools to help you make VAE determination much more easy. Share the protocol with your colleagues in respiratory care, critical care, and the laboratory. They can really help you to understand elements of the protocol that you're maybe not so strong with, such as some of the uncommon forms of ventilator support, or how to determine if a semi-quantitative or quantitative result are analogous. We routinely receive questions related to reporting requirements. VAE is not currently in CMS Hospital Inpatient Quality Reporting Program for Acute Care, or IRFs, and as of October 1st, 2018, it is not included in the program for LTAC facilities either. However, my understanding is that there are state or local jurisdictions which may require you to report. If you are unsure, I encourage you to reach out to your HAI coordinator from your state health department to help you identify any regulations which you may be subject to in your facility. So to summarize, when conducting VAE surveillance in plan, you must report all events detected at the highest level that is met in the algorithm. All patients must be assessed for VAC, then IVAC, and then PVAP. You cannot elect to perform surveillance for only one or two of these events. For instance, you can't only survey for PVAP. You have to perform surveillance for all 3 events, but remember it is a hierarchy, so you'd only report the highest level of event that was met for each patient. When reporting VAE, remember events are not upgraded within the 14-day event period. For example, if you identify an IVAC on mechanical ventilation day 5, making the 14-day VAE period days 5 through 18, a specimen collected on mechanical ventilation day 10, which may satisfy the criteria for PVAP 1, but because the collection date was outside the VAE window period, you would discard that. You would not consider that a PVAP. You would not upgrade the event. This is a screenshot of the VAE paper data collection form. Your reporting will be done electronically in NHSN, but this form will show you the fields that are required to be reported, which can assist you with your data collection efforts. Required fields are denoted with an asterisk and must be addressed before the event can be saved in NHSN. You are required to indicate a location in which mechanical ventilation was initiated, as well as the date. And this references where the patient was intubated or where mechanical ventilation was initiated on a trached patient. And this might have occurred in a non-inpatient location, for instance, in your emergency room or by EMS. So you may have to map some outpatient locations in order to be able to answer this question accurately. Also in the past, aprv has been a required field, but it is no longer required, so you'll notice that there is no asterisk there. It is optional to report, but many facilities do elect to report this, and if you answer this question, then you can later run analysis on this if you're interested in that. And then you want to select the criteria that were used to meet each of the VAEs. The same format is found when entering the data into the NHSN application. For the most part, the paper form mirrors the application. You want to select VAE as the event type, which I have is indicated up there in red. Notice that this has a red asterisk indicating it's a required field. This is in contrast to optional fields such as aprv. And we also have, you'll have to select the specific type of event that you're reporting. You'll enter the specific elements which were used to meet the criteria. And remember, since this is progressive, you will have to select elements for VAC. And then if you're reporting an IVAC, you'll have to also select the elements that were used for VAC and IVAC. And likewise with PVAP, you'd have to select your VAC, IVAC, and PVAP elements that were met. Device or ventilator days are used in data analysis, such as for the denominator for VAE rates. Ventilator days include patients in the eligible location who are ventilated at the time of the count. All patients with a ventilator are counted, not just those that are eligible for VAE surveillance. And patient days are determined by the number of patients in the eligible location at the time of the count. And this information is used for to calculate utilization ratios. Some practitioners or facilities prefer to use episodes of mechanical ventilation as their denominator. This is entirely optional. This is determined by the number of patients on mechanical ventilation at the first day of the month, and then for each subsequent day, you would count any new patients that have started mechanical ventilation. So based on what you have selected in your monthly reporting plan, you would find a red asterisk by the denominator fields that are required. In this example, VAE was selected for the location, which is a cardiac ICU, in the monthly plan for January. Patient days and vent days are required. Note that aprv in episodes of mechanical ventilation does not have an asterisk, as that is optional. Okay, so next we're going to talk about the VAE Calculator. This version 6.0 is hot off the press. It just came out a couple weeks ago. This incorporated some of our recent updates, such as we changed our level of FiO2 from 20 to 21%, because of course room air is 21%, so it didn't make much sense to have 20 as an eligible reading. And there was an addition of a new agent, antimicrobial agent, meropenem. How many of you use the calculator? Yeah, it's a handy tool. When I was an IP, I used this for all of my, to determine all of my VAEs. But it's important to know that this does not replace the protocol. You still have to understand the protocol in order to be able to use the calculator, because if you don't give it good information, it will not give you the correct determination. For example, it won't know if the patient is on aprv. So if you are putting 0 for your PEEP, it's going to autocorrect that to 5. And then it may establish a baseline period of stability, which may later trigger a VAC when there really wasn't a VAC, because you shouldn't be filling out the PEEP field for that, that form of ventilation. On the landing page, you will find a few specific instructions and information. I've highlighted a few things that I wanted to mention. First, if you select this More link, it will expand this box. And it's important to know that the calculator runs locally on your machine. Any data that you put in there is not being transmitted to NHSN. We won't know anything about it. It won't be uploaded. It won't count as anything. It's just a way for you to go in and use this tool for your own events, but also to play around with it and become familiar with it. You want to select your, go down and select the calendar for your start date. Some patients may be on mechanical ventilation for a prolonged period of time. You don't have to start with the very first day of their ventilation if it was really not doesn't have a temporal relationship to the VAE that you're looking at. But you want to select at least 7 days before, just so you have enough of that prior information before the window. Also note you can't select any dates that are in the future. So now on this screen, you'll enter your PEEP and your FiO2 values for the dates that you have selected. And then you'll use your mouse to hit Calculate VAC. Note the calculator considers PEEP values in the range of 0 to 5 is equal to 5 when making the VAE determination, and this will be autocorrected by the calculator. The calculator also will highlight the VAE window period in peach so that it's easy to identify. The Explain button is one of the features that makes the calculator a very nice learning tool by providing an explanation of how the calculation was made. Here you can see the explanation was provided about the VAC criteria which were met. Once a VAC is met, click on Go to IVAC to determine if the patient meets the IVAC criteria. Okay, so now that we have a VAC, you want to place a check mark in the boxes where the temp and or white blood cell count meet the IVAC criteria within that VAE window period. Once you've done that, you will select your antimicrobial agents that the patient was on, and then you'll check any dates that that antimicrobial agent was administered. Remember, any of the available check boxes you should select if it was administered on that day, even if it was before or after the VAE window period. All right, so once the antimicrobial data has been entered, you want to click Calculate IVAC. If an IVAC was identified, the determination will change from VAC to IVAC. And also note the calculator will identify the QADs as noted on the far right-hand side of this slide. You want to click on the explanation button for the rationale. And again, this will help explain the criteria that were used to determine if the IVAC criteria was met. After you have met the IVAC definition, you'll want to move to PVAP. The PVAP box will pop up as indicated in this red outline. The VAE window will be identified. The 3 PVAP criteria are listed, and if any of those criteria are met during that window period, you will select the corresponding box for that PVAP. And then you will calculate PVAP. Use the Explain button to provide you with the event type and rationale for the VAE criteria that was met during the time frame. You can see here that the VAE type changed to PVAP. If your patient did not meet PVAP, then IVAC would remain. The calculator is a great resource and a complement for your VAE surveillance, but remember, it is not a substitute for knowing and understanding the protocol. And that is the end of my presentation. If anybody has questions.
My question is, we have a lot of patients who are on ECMO, and when they come off the ECMO, I just wanted to make sure, so like if it was discontinued today, sometime in the day, I start looking at their ventilator, for my days of stability starting tomorrow. Is that correct? Or
if their ECMO was discontinued today, then you would start looking as soon as they go back onto a conventional mode of ventilation. So if it was discontinued at some point today and they went back on a regular ventilator, then you would count today.
Oh, you should already start looking for your day of stability today. In other words, as soon as they're off.
Correct.
Okay, and decannulated. Okay, thank you.
Thank you.
Okay, we have a couple questions from our live streaming audience. And the first one, Tara, is, are PEEP and FiO2 values documented while the patient is in the operating room used to determine lowest minimum values for the day? Or do we only look at values charted while the patient is physically located in an inpatient unit where surveillance is being conducted?
Right, so they have to be on an inpatient location.
We would be including all, they have to be in an inpatient location for eligibility for surveillance, but if you've got documented values while they're off of the unit, you still, all of those would be used to select when you're selecting your daily minimum value. But we use the OR values. Okay, so even though the OR is not a bedded location, you still would use values documented while the patient was on the ventilator. That's what for VAE surveillance,
I would like to introduce Cindy Gross. She is my co-SME for VAE, and she has been here since the beginning and helped develop this protocol. And she's brilliant and has been teaching me everything that she knows about VAE. So she might step in and answer some of the questions because she understands a lot of the nuances really well. So I just wanted to introduce Cindy.
All right,
Thank you,
thanks,
Cindy.
Sarah. Okay, another question. Let's see. We had a question from someone that they're asking why there is no separate SIR for PVAP. And I'm going to defer that question. We have the analysis group is going to be giving a presentation after we go through the case study. So we'll hold that question for them to answer. And then the final question that we have from the web streaming audience is, I checked the CMS requirements for acute care hospitals and noticed that VAE reporting is not on that list. Does NHSN require HAI VAE reporting?
No. NHSN, for our purposes, we do not require anything. We are a mechanism for you to report your events into, but you may have other entities that require you to report into NHSN, for instance, CMS or some of your state regulations may require that. So no, we don't have any requirements, but we are the venue for you to report those events.
Yeah, hi. I'm just curious about not being able to upgrade to PVAP if it's within the 14-day period. Mm-hmm. If it falls outside of the window period, it just seems like, there might be a delay potentially in doing a bronch or something and getting that specimen. And why did we make a decision not to do that? I know you've laid it out, and I really did not know that until you did. So I was just curious because obviously that would be the highest tier, and you wouldn't want to call it an IVAC when it really was a PVAP, right?
Correct. I'm going to let Cindy, if you don't mind, just because she understands the history of how that decision was made.
Yeah, so there is not updating within that 14-day event period for standardization. Also, because the working group decided that we're giving you it's a grace period. And so everything is to occur within that window period. So they just did not want to be continuing to look for things after the VAE window period, primarily for standardization. And keeping in mind that IVAC and PVAP are not to be considered worse, or it's not that you only pay attention to your PVAPs, or you only pay attention if you meet the IVAC tier. Meeting VAC is the foundation, and it's based on worsening of oxygenation. So even if it progresses and we change the protocol, really the point that we're looking at is worsening oxygenation. Meeting those subsequent tiers are maybe to help you drill down, find out maybe what triggered it. Possibly it's related to infection. It may not be related to infection. Possibly it's related to a lower respiratory. It may not be, but the focus is on meeting the VAC definition. Hopefully that helps.
All right. Thank you. Oh, one more question back there.
Okay, so I'm a Pennsylvania person. So if I am doing VAE surveillance and I call an IVAC, and then we have the positive lab, we can't link it to that if it's within the 14 days. So then would I potentially be calling a VAP and a PVAP on that person? Because I have to attribute the lab to something.
It is possible to have both a VAE and an event that meets one of the criteria in the pneumonia protocol as well. So yes, that is possible.
And it's possible that you can meet pneumonia and VAE. They're two separate events.
Right.
But your last statement that you were saying you have to attribute that lab to something.
Well, anytime we have a positive micro,
Right.
we have to attribute it to something unless it doesn't meet the definition, right? Like we don't see the positive micro and then just ignore it. We have to ensure that it doesn't meet any definition anywhere before deeming it not relevant or whatever. So.
Okay, right. And so in your case, in Pennsylvania, if that lab could be used to meet a pneumonia definition, then it's my understanding that you have to report the pneumonia.
Okay. Thank you.
Okay, any other questions? Thank you.